Hello, and welcome back to whatever this is. I was about to read a book aloud to pardnerrrr on iPad, and sorry, I was holding back a cough. I'm still a little Lord almighty. Pardnerrrr is staring at me and sniffling back and picking his nose. So I was gonna read this book out loud, and then I realized that I could just record that, and that's what we're doing. I'll just shut up and get started now. Alright. It's called Sex Matters: How Male-Centric Medicine Endangers Women's Health and What We Can Do About It, by Alison J. McGregor, MD, Director, Division of Sex and Gender in Emergency Medicine, Alpert Medical School, Brown University. Alright, I'll read the sleeve of the book. So it says, women are different from men in every way, from their DNA on up, but the male-centric model of medicine is so pervasive in our healthcare systems, procedures, and philosophy that many don't even realize it exists. Most people simply assume that women's differences are already being taken into account, yet nothing could be further from the truth. Physician and leading expert Dr. Alison McGregor is on the front lines of sex and gender-based medicine. In Sex Matters, she exposes one of the most urgent issues facing women's health today. All medical models in research and practice are male-centric, erasing the unique biological and emotional differences between men and women. This bias can actually jeopardize a woman's life. We need to reinvent modern medicine to include, accommodate, and ultimately empower the other half of the human population that has been, until now, marginalized and left behind. We need a roadmap for doing this, and Sex Matters offers just that. This definitive account shows how the biological, biochemical, psychological, and neurological differences between men and women affect issues such as preventative care, emergency care, drug prescriptions, and pain management. Dr. McGregor also looks at how race, class, and gender identity are disproportionately affected by this bias. Ultimately, her message is one of hope and a way forward. With clear, actionable steps, Dr. McGregor shows us what we can do to get all the women, all the women, huge women, all women the health care we need and deserve. Alright. I hope that the page flipping just sounds like ASMR. We can skip the praise. Alright. I will read the dedication because I think dedications are cute and gay. This book is dedicated to all the women I've had the pleasure to care for, who taught me about their illnesses and insight. All the women whose struggles I have witnessed through our medical system, through everything from lack of understanding to questioning self-reflection to endless testing that leaves them feeling dismissed. They have persevered. And also to my mother and sister, with immense love and gratitude. As I studied medicine, I watched the two of you navigate our medical system from the outside. You helped me see the full circle. See, that was cute and gay. Pardnerrrr is smiling. I guess pardnerrrr has just stuck, like that pronunciation. I just keep saying that every time I'm recording things. Alright, introduction. As an undergraduate in the University of New Hampshire's pre-med program, I took only one elective that wasn't directly related to my major, or at least I thought at the time that it wasn't related. That course was women's studies. Women? Just kidding. I love circling up with other women to talk about the history of women in society and the gender-related issues we faced, both individually and collectively. It was illuminating and truly inspiring. When the class ended and our spirited discussions were replaced in my schedule by yet another biology lab, I felt like a bit of the spark had gone out from my collegiate life. I didn't know it at the time, but that course and the questions about sex, gender, and the female experience it sparked in me would have a profound influence on the trajectory of my career. When I finished medical school at the Boston University School of Medicine, I applied for a residency at Brown University in my hometown of Providence, Rhode Island. When my residency ended, I wanted to stay on and work there. Because Brown is an academic institution, I needed to choose a research focus in order to apply for a long-term position. When I sat down and thought about it, the only path I wanted to take was one that would improve the lives and health of women. I wanted to know about women's bodies and how those bodies were affected by modern medicine, affected by modern medicine, in particular emergency medicine. At the time, sex and gender research didn't even exist. My choice to pursue a specialty in women's health felt like a nod to my feminist beliefs and personal philosophy, a way to keep feeding my passion for women's issues. I had no idea just how deep an ocean I was diving into, or how many challenges I would face in bringing women's unique health concerns into the medical mainstream. When I mentioned to my advisors that I'd like to explore fields related to women's health, the immediate reaction was, "Oh, you want to do OB-GYN?" "No," I'd reply, "I want to study women's health holistically, as in the overall health of women." No one seemed to know what I meant. This was my first clue about what was really happening in our medical establishment. As I discovered, and as I'll share in this book, there is far more to women's health than pelvic exams and mammography. Mammography means the imaging and study of the boobies, or as medically known, the breasts, which are an organ of the female body and intersex bodies as well. Alright, I readjusted so I could breathe better, but I'm still, it's gonna sound chainsmokery no matter what I do. But I can't wait for my voice to recover before I keep living life and doing things, so, And also, I'll make a video on this at some point, but I think part of why I feel like it's a useful thing of my time alive to record and yap and comment about books that I read is because I like to read. I spend a lot of time reading, and I know people struggle a lot with nonfiction reading, especially things like this where it's written by someone who's so deep and niche in their field that they're an expert, but sometimes people don't know what things like mammography means. And I'm not saying that this book is going to be this author basically speaking too formally or whatever. I doubt that that's the kind of writing that this is going to be. I think a lot of stuff is going to be well explained just from the way that the book is started, But it is a random book I picked up at the public library, and I felt like reading because it caught my attention, and it's something that I'm interested in, And I think people forget that that's a thing that you can do because we all have little dopamine devices that give us information in different ways. And I'm connecting with you now through that dopamine device, this is now a video or just audio for you in the background, whatever it is. But, where was I going with this? Oh yeah, my point was I still think that if people are gonna be just watching things, I might as well try to contribute by taking these little snippets of my life when I'm doing things that aren't brain rot and are good for my brain, not even just my brain, my heart, my soul, my future as a healthcare practitioner and human being and female in society, yeah, that's all. I'm gonna keep reading now. Jeez, I be yapping. Okay. no one seemed to, so I want to study women's health holistically, as in the overall health of women. No one seemed to know what I meant. That was my first clue as to what was really happening in our medical establishment. As I discovered, and as I'll share in this book, there's far more to women's health than pelvic exams and mammography. Women are different from men in every way, from their DNA on up. The medical practice of differentiating women from men according to their reproductive organs alone is both reductionist and, as it turns out, hugely problematic. But the male-centric model of medicine is so pervasive in our healthcare systems, procedures, and philosophy that many don't realize it exists. Most people simply assume that women's differences are already being taken into account, yet nothing could be further from the truth. My research on and passion for this issue has placed me at the forefront of a medical revolution. As a researcher, educator, speaker, and physician, I and my colleagues in this cutting-edge field are tasked with it is getting gravelier and gravelier, my voice, are tasked with integrating emerging information about women's health into the mainstream medical culture. We are advocates for women and their unique bodies in a system that has largely ignored them, marginalized them, and minimized them. We are women and a few good men taking a stand for women in a way that has never been done before. Awareness is the first step to change. As a nationally recognized expert on sex and gender medicine, I have been made... Oh my god. I'm sorry, I'm very distracted by my own voice right now. Okay. Where was I? I have made researching and bringing awareness to health disparities between men and women across all areas of medicine my life's work. In addition to my day job, seeing patients in the emergency department of an urban trauma center and dealing with everything from colds to car accidents, headaches to heart attacks, and broken bones to overdoses, I wear a few other hats. I'm the division director for the first program in sex and gender emergency medicine at the Alpert Medical School of Brown University, and co-founder of the Sex and Gender Women's Health Collaborative. I am also a sought-after visiting professor and grand round speaker at medical institutions across the country, and I'm a keynote speaker for community advocacy groups including the Laura Bush Institute for Women's Health, the Barbara Streisand... Okay, I'm gonna skip these. I don't need to read all of these out loud. My voice is already so tired. She's an amazing person and does a lot of cool things. Anyways. While much of my work is let me drink a sip of water. Hold on. You should drink water too. No, it's empty. There was like a baby sip. No, there was a baby sip. I'll fill it up later. That's fine. This is a lot harder than I thought it was gonna be. Okay. Maybe I should have worn like one of the nasal strip thingies. Well, much of my work is accomplished within the medical community itself, through educating medical students and professionals, advocating for changes in research guidelines and pharmaceutical prescribing standards, and conducting research on sex and gender issues. Changing the system from within is only half the battle. The other half is educating the women whose lives and health are being impacted by the system every single day. So true. The patients must be educated as well. I agree. My TEDx talk, Why Medicine Often Has Dangerous Side Effects for Women, was intended to open the eyes of women around the world to issues discussed in this book. Every time I talk about sex and gender issues in medicine, I hear stories from women about how the system has ignored, minimized, or outright failed them. This failure of care may not be intentional on the part of women's doctors and providers, but neither is it acceptable. How to use this book. While this book contains facts and observations that you may find revelatory or even shocking, my intention is for it to serve as far more than an expose. Ultimately, information is more useful when it is actionable. It's not enough for us to merely observe the scope of the problems women face in our modern medical system, or even to voice our feelings of anger and betrayal at what we see. We need to always be asking, what can we do about this? This book is intended to be both informative and prescriptive. By the time you turn the last page, I hope you will understand not only how male-centric medicine affects women in both broad and specific terms, but also exactly what steps you personally can take right now to begin to reduce your personal risk factors and make grassroots changes in your local medical community. In part 1 of this book, we will look at the broad picture of male-centric medicine, how it came to be, how it works in practice, and how its lack of recognition of women's physiologic differences is jeopardizing the health of women across America and the world. In part 2, we will look at specific disease patterns and areas of health that impact millions of women across the country, including heart attacks, strokes, pain disorders, pain management, and pharmaceuticals. We'll also look at the role of women's hormones, biochemistry in various areas of health, as well as at how issues and biases related to gender, race, and ethnicity, and religion affect medical treatment and outcomes both subtly and explicitly. That was a mouthful. In part 3, I will write you a prescription for action. We will look at how the landscape of medicine is changing for the better and how you can tap into existing resources to take a more active role in your own healthcare. In Chapter 10, I'll share specific questions you can ask your providers to help you get the answers you need, as well as resources to assist you in your own research. By picking up Oh my god, I'm breathing like I have emphysema right now. Not to insult my very wide fan base of emphysema patients at this time and future times, I guess. I don't know. Oh my god. Lordy, when will this go away? I was telling partner that in high school, whenever I got October sniffles, I used to have a cough and my voice would sound like Doja Cat on steroids, like this, for months, basically, until Mariah Carey's I don't want a life for Christmas, would come into town, and only then would my voice return to normal. So I'm really hoping it doesn't last that long, because I sleep a lot better than I did as a high schooler. I'm much more well-rested and have better nutrition and vitamins and things. And I definitely probably drink more water, so I don't know what I'm saying, as usual. Okay. By picking up this book, you have become a part of a movement for change. You have chosen to educate yourself about the realities of how modern medicine treats women and their bodies. Throughout this book, I will give you tools to translate your new awareness into advocacy for yourself and for other women like you. As a patient and as a woman, you have a voice, and your voice matters. This book will equip Oh my god. This book will equip you to use your voice effectively in a medical setting. You'll learn what questions to ask, what pitfalls to look out for, what tests to request or avoid, and what resources to employ so that you can receive the quality of care you need and deserve. Effectively, you will become a more equal partner in your own healthcare. I like that statement because that's one of the first things we talked about when we were talking about medical ethics and when med school started, was the power dynamic and how much that, like, you need to be aware of that as a practitioner. Even if you're a nurse, anyone in a position of authority above a patient needs to be aware that the patient is in a vulnerable position. And I've seen so many videos of the, mean girls to mainly nurses pipeline for whatever reason. I don't know why, I'm not saying all nurses are mean. Absolutely not. I want to make like many videos about nurse appreciation and things like that, especially because partner mama is a nurse, and she went to nursing school, and she's a kick-ass nurse, and you know, that's something that I've gotten to see firsthand now, was like that schooling process. And I got to see, like, at the graduation, a lot of the other like professors that were teaching at the school and stuff, and I heard them speak, and it was cool because like there's a different, I think one of the problems among the many in the healthcare industry right now is that's part of the problem in the healthcare system, is the disconnect between like the levels of hierarchy. Like doctors to nurses is apparently like this big ego match where doctors think that they're above nurses like all the time, and it starts right from med school. You know, that culture of you're above someone because you're going to be a doctor. Me and partner have seen it firsthand in med school, and it is ridiculous because like, how are you not even a real doctor yet, and you are like trying to act as if you're better than your patients, and you haven't even laid a finger on them yet, you know, for good reason, granted, but you know, there's a very big disconnect in the superiority complexes of those who are just a smidgen higher up, which is silly because one, a lot of doctors that practice are people that practice because they had the privilege to access everything needed to get to the point of med school, you know, but that's for another video, you know. And on top of that, that's not in the benefit of the patient, you know. So at the end of the day, like, every human is a human. Every part of the machine, every cog in the wheel is equally as important. But people are people, and yeah, I don't know. It'll be interesting to talk more about, but it's like, even outside of the fighting amongst the practitioners and who thinks they're better than the other, there is the fact that they all think that they're better than the patient at times. Even the techs, you know, techs as in like, a lot of times in large hospitals, or even small hospitals, I guess, I don't know, hospital settings mainly, there are people who, they aren't nurses, but they are certified for patient assistance and moving, transportation, things like that, depending on needs of certain patients, you know, especially like patients who have open, like, not open, but like recent surgical wounds and things like that, where like you don't want to necessarily have a random person moving them if they need help going to the bathroom or getting up or walking around or things like that. You might want someone that knows how to work with patients in order to help them move around based on their current situation and fall risk and things like that, you know. And so that's what patient techs are, you know. But I've seen, even in my own volunteer work and you know, well, like as a student of medicine, but not always a medical student, like in my pathway up to now in various hospital settings, you know, I've seen this at every level of the hierarchy, where people think that they're better than a patient, and it sucks. It's sad, you know, but yeah, patients deserve to have a say in what's going on in their own healthcare, and the best way towards empowering them to have that, empowering patients like you, viewers like you, again, is to educate them, you know. And patient education is something I want to do in my life. I don't know, it definitely is a purpose that adds a lot of value to the irritation that studying can be sometimes. The endless abyss of textbooks and whatnot. But yeah, anyways, the last little bit of this introduction, because I never shut up. On the next page, you will begin your journey into the discovery of women's health as it stands in our current medical system. You will learn things that will surprise you and many that may distress you. But in the end, I hope that you will find in these pages a feeling of empowerment and the knowledge that you need to become a voice for your own health and the health of women everywhere. Are you ready to get started? Oh, yes, I am. Let me in. With the hair on my chinny chin, or whatever. Okay, part 1, how we got here. And I guess I can read chapter 1. And then I might stop there. How long is it? What? Okay, we'll see how far I can get, whatever. Chapter 1. Modern medicine is male-centric medicine. So true, bestie. Or should I say, because it's a book about women's medicine. So true, breasty. Sorry. I'll never forget the day that a 32-year-old woman almost walked out of my emergency department while having a heart attack. In emergency medicine, there are many algorithms by which we evaluate risk factors and stratify incoming patients. Not everyone who walks through the doors of the ER is an emergency department. I'm just going to keep using that instead of reading the word. Since she's an emergency doctor, I figure she's going to type that a lot. So, anyways, not everyone who walks through the doors of the ER is on death's door. So we treat the most urgent cases first. For example, someone who is asphyxiating or suffering from a stab wound will be regarded as higher priority than someone suffering from non-specific pain or who just doesn't feel quite right. This risk assessment makes sense theoretically and works fairly well in practice too. But once the obvious cases have been dealt with, we're navigating a large gray area. Unfortunately, the subtle and often subjective strata by which we prioritize patients who don't appear to be at immediate risk are far more perfect, particularly when those patients are women. Women are different from men in more ways than just merely the obvious, and nowhere is this more apparent than in the halls of the hospital where I work and teach every day. For example, the research upon which our stratification procedures are based cites that things like estrogen protective effect, meaning the way that the blood estrogen levels appear to reduce or modify traditional risk factors like oxidative stress, arrhythmia, and fibrosis in premenopausal women, and the supposedly low statistical likelihood of premenopausal women presenting with acute heart conditions. Okay, hold up. That was a lot. Let me dissect that for a sec. For example, the research upon which our stratification procedures. In other words, even if a young woman were to come into the ED and say, I think I'm having a heart attack, unless she displayed blatant and very specific symptoms, most doctors would immediately look for another explanation. Yeah, okay, so basically the previous sentence was just trying to say that there's an estrogen protective effect, so a lot of times women come in appearing to be less sick than a man who may come in with a similar condition, something like that, and a lot of times this is the case with heart attacks. It was something that we talked about as well. Like, for example, we're told that there's like a pain that people often have, which we've seen in like movies and stuff, like the clutching the left side of your chest above your heart pain, and we're told like, yeah, like a patient can come in with pain in the left side of their chest that might be radiating to their shoulder, it could even go all the way down their left arm towards the back. That type of pain oftentimes is less prevalent in female populations, which when I found out was wild, because like as a young person before I knew any medicine, that was like the number one thing I thought heart attacks like were kind of related to. It's what everyone's told, and it's crazy that a issue that is so deadly and so prevalent in the global population, like most people don't know the symptoms, most people don't know when to take action. Same applies to strokes. Like I remember trying to tell my family about what stroke symptoms are. Like most people don't know about them, and that Like, just teaching people about that sooner can be the difference between, life and death, so. I started yapping again, oh god. Okay. Julie, the young woman I met that day, oh my god, had visited her primary care doctor several times prior to coming to the emergency department and had also seen at least 2 other physicians in the previous 48 hours. She was experiencing discomfort in the region of her chest and shortness of breath that worsened markedly the more agitated she became. I was working in the critical care area when she came in. Immediately, I thought to myself, this woman doesn't look good. I had a gut feeling that something was really wrong. Her other doctors had attributed Julie's symptoms to a combination of anxiety and stress to her heart due to her obesity. The vagueness of her descriptions when she talked about her symptoms, combined with her age and the fact that she had been clinically diagnosed with anxiety several years before, made her current discomfort seem like a no-brainer for her doctors. She was having panic attacks and her weight was compounding the issue. End of story. However, as a specialist in sex and gender medicine, I knew that during an MI, which is short for myocardial infarction, aka heart attack, and other cardiovascular events, women often present much differently than men. In fact, women's cardiac symptoms are often described as atypical and unusual in medical literature. While men have... Oh my god. Sorry. My nose is so clogged up. Okay. Julie was... Nope, that's not where I was. And... while men might experience pain radiating down the left arm, chest heaviness, or other stereotypical signs of heart attack, women often present with only mild pain and discomfort, possibly combined with fatigue, shortness of breath, and strong feeling that something isn't right. Julie was very pleasant, but I could tell she was scared. I calmly explained that while her current issue might be exactly as other doctors had described, I would be more comfortable if we ordered an electrocardiogram, also known as EKG, and blood work to make sure that things looked normal. When we got the results, I caught my breath. There was something very wrong here. This could actually be an MI, I thought. Oh my god, my nose is killing me. This is awful. I'm being a baby. I just think it must sound very annoying, and I know I'm not gonna edit it. Anyways, I immediately called our attending cardiologist. I believe this woman is having an MI and needs to go to the cath lab. I told him the cath lab is the medical site where a procedure to fix blocked arteries is performed. A 32-year-old woman. There was a slight pause, and then a sigh. Oh, all right, I'll send someone down to take a look. Then a sigh. Oh, wait, no, I just read that. I'm all over the place. My nose is very distracting. Alright. How much? 32 minutes. I could probably wrap up in a little bit for this one and continue reading. What do you think? There's a section header coming up. I'll stop there then. Okay. I immediately... Nope, I already read that. Oh my god. Maybe I need a nap. Like Julie's previous doctors, the cardiologist's assessment was that she was simply displaying symptoms of anxiety, but her EKG was slightly abnormal, so he finally agreed to take her to the cath lab. About an hour later, I got a call from the cardiologist. Dr. McGregor, the attending cardiologist, began, sounding a bit astounded. I wanted to let you know that your patient, Julie, had a 95% occlusion of her main coronary artery. We placed a stent to restore blood flow to her heart. An occlusion of the main coronary artery in a man is often called a widowmaker. We see it all the time in men over 50 and in a number of postmenopausal women. And yet here was a sweet 32-year-old Julie presenting with a condition that was likely to kill her in weeks, if not days, if left untreated. And no one had thought to look for it because her symptoms and risk factors weren't consistent with the classic male model of a heart attack. Thankfully, Julie pulled through the procedure and recovered. I didn't see her in the ED again, but her story has stayed with me. Sometimes I wonder how many other women like her walk out the doors of other ERs every day without receiving the life-saving treatment they need and deserve. Even one is too many. But I have a feeling that the number is much, much higher than that. And I'll stop there. Even one is too many is so true, breasty, because every single one of those patients is a life. It is someone out there who deserves the best healthcare, you know? That's all. Any comments from you, my dear? Thumbs up. Alright. Peace out. Bye-bye. Take care of the women in your life, y'all.